All right, let's dive into a pretty fascinating case study, huh?
Yeah, this one's definitely a head scratcher.
It is. So we're talking about, let's just call her Emily, a 32-year-old woman who arrived at the hospital.
Yeah.
And let's just say a lot of things are going on.
Yeah, Emily's case, it's really interesting because it kind of throws a spotlight on infective endocarditis. And it can be, well, it can be tricky, you know.
It can be tricky.
Yeah.
So infective endocarditis, for those of us who aren't, walking around with stethoscopes every day,
Yeah.
what is going on in Emily's heart?
So think about it this way. You know how your heart valves, they're like these really precise doors?
Okay.
And they control the flow of blood through your heart. And now picture like a tiny, jagged ball of bacteria that's clinging to one of those valves and like disrupting that whole smooth flow.
Wow.
That's basically what infective endocarditis is. It's this infection that takes root on the heart valves.
Not good. Not something you want to have. So what set off alarm bells when Emily arrived? What made the doctors even think about infective endocarditis?
Well, first of all, Emily has a history of IV drug use.
Yep.
And that's like a major risk factor.
Oh, okay.
And then you add to that, she came in with a fever, a rapid heart rate, even showing some signs of confusion.
Yeah.
All big warning signs, especially with her history.
Especially with your history, yeah. Okay. So how do doctors move from, thinking about this to an actual diagnosis? Is there a specific test? Like how do you pinpoint infective endocarditis?
It's not always like a straight line.
Okay.
But there's this tool called the Modified Duke Criteria, and it helps doctors assess the likelihood of it, even before they have all the results, Think of it like a detective's checklist.
I like that.
Right.
A checklist?
Yeah. Clinical signs, symptoms, preliminary findings, all that.
Okay, so pop quiz then.
Okay, I love it.
Which of these is not a minor criteria in the Modified Duke Criteria?
All right. You ready for the options?
Yes.
A, fever over 38 degrees Celsius. B, IV drug use. C, positive blood culture. D, septic pulmonary emboly.
Those are some tough choices. All right, I think I'm going to go with C. Positive blood culture.
You are absolutely right.
Yeah.
That's actually a major criterion.
Major criteria.
Not a minor one.
Okay, got it. So they're looking for all those things. Even with limited information, they can start piecing together the puzzle.
Exactly. And for Emily, even before the lab results were back, she already met several of those minor criteria just from what they saw when she came in. That's why they were already thinking, this could be infective endocarditis.
Oh, wow. So left-sided, more worrisome. Okay, what about right-sided infective endocarditis? What's the story there?
So right-sided IE typically involves the valves that send blood to the lungs to get oxygenated,
Okay.
It tends to be generally less severe. But here's where Emily's case gets even more interesting.
Ooh, I like when it gets interesting.
Do you remember those symptoms? Those kind of alarming symptoms? Well, they also pointed to something else. Sepsis. Her body was mounting this, massive life-threatening response to the infection.
Oh, wow. So even though right-sided infective endocarditis is usually not as bad, the sepsis is like a whole other wrench in the works.
Exactly. You got it. It takes what might have been, a little bit more straightforward to a whole other level of seriousness. Medicine's rarely straightforward. Always got to keep you on your toes.
Yeah, always. Always interesting cases. All right, so we've talked about the diagnosis, but obviously the big question is, how do you treat this? I mean, we're dealing with an infection, so I'm guessing antibiotics are going to be key, right?
You got it. Antibiotics are absolutely crucial. But with Emily, even choosing the right antibiotic, gets a little complicated because she's reported a penicillin allergy.
Oh, okay. So that throws a wrench in things.
It does. It does. So, what's the gold standard antibiotic treatment for Methicillin-Susceptible Staph aureus endocarditis, or MSSA?
Okay, well, let me think. Is it A, Vancomycin, B, Cephalosporins, C, Napsillin, or Oxacillin, or D, Daptomycin?
All right, you got all the big players there. Which one are you leaning towards?
I'm going to go with C, Napsillin, or Oxacillin.
Bingo. You're absolutely right.
Yes.
Napsillin or Oxacillin. Those are the go-to choices for MSSA endocarditis. But here comes that allergy again. Throws a wrench in things.
Oh, man. So what do you do in that situation? I mean, can you even use those antibiotics if someone's allergic?
It's tricky, but there are options. One thing we can consider is penicillin skin testing.
Oh, so you can actually test to see if the allergy is real.
Yeah, it can help us figure out if it's a true allergy or maybe just, something that happened in the past that's not an issue anymore. Because, Allergies, they can change over time.
Yeah, that makes sense. But let's say, for argument's sake, that the penicillin allergy is confirmed. What's plan B? Is vancomycin a viable option?
Vancomycin's often the first thing that comes to mind, but it's not necessarily the best choice.
Really? Why not? I mean, I feel like I hear about vancomycin all the time as a powerful antibiotic.
It is, but it's a big gun, and it's not always the most effective for endocarditis. The guidelines actually recommend against using vancomycin as the first-line treatment in this situation.
Interesting. It seems like sometimes even experienced doctors get surprised by these specific recommendations.
You're telling me. It can be a real head-scratcher. And, Emily's case gets even more complex because of those septic pulmonary emboli we talked about.
Right, those blood clots in her lungs. How does that factor into the antibiotic choice?
Well, Daptomycin, option D from our quiz earlier, that's another antibiotic that can be effective against MSSA. But there's this ongoing debate about its effectiveness in cases where you have lung involvement.
So even with all these advanced antibiotics, it sounds like there's still a lot of uncertainty in gray areas when it comes to treating infective endocarditis.
That's the thing about medicine. It's not always black and white. There's a lot of nuance and a lot of individual factors to consider.
Okay, so we've got our antibiotic conundrum. Now, how long does someone typically need to be on these powerful drugs? I mean, we're talking about a serious infection here.
Right. We're talking weeks, not days. For infective endocarditis, the standard treatment is usually a long course of IV antibiotics, like 6 weeks or even longer.
Wow, so this is not a quick fix.
Not at all. But here's another interesting twist, and this applies specifically to cases like Emily's. For uncomplicated right-sided endocarditis in IV drug users, there's this possibility of a shorter 2-week course of antibiotics.
Wait, really? That seems like a huge difference. Why would a shorter course be an option in this specific scenario?
Well, for starters, it might improve adherence to treatment. Getting someone to commit to 6 weeks of IV antibiotics is a big ask, especially for someone struggling with addiction who might have other challenges in their life.
That makes sense. But I imagine there must be some hesitation to go with this shorter course. What are some of the concerns?
The big one is the risk of relapse. If the infection isn't completely eradicated, it can come back with a vengeance.
So it's a balancing act, weighing the benefits of a shorter course against the potential risks.
Absolutely. And it's a decision that needs to be made on a case-by-case basis, considering all the individual factors at play.
It sounds like Emily's case is really challenging our assumptions about how we approach infective endocarditis. We're seeing how even the seemingly straightforward aspects of diagnosis and treatment can get really complex when you factor in the whole person.
Exactly. And that brings us to another crucial aspect of Emily's care, addressing the root cause of her infective endocarditis.
You're talking about her substance use disorder.
Right. It's not enough to just treat the infection. We have to address the underlying issue that led to it in the first place.
Okay, so let's talk about that.
All right, let's dive in. It's easy to get caught up in the immediate crisis, right?
Yeah.
With the infection and the sepsis. But we can't forget this isn't just about treating, an infection in isolation. It's about Emily, her life, her story, everything that's going on.
You're absolutely right. I mean, we have to talk about Emily's substance use disorder.
Yeah.
I mean, it's not just a coincidence. It's the root cause here.
Exactly. And addressing that root cause, is just as important as those antibiotics we were talking about. Think of it this way. If you have a leaky faucet, you can keep mopping up the water, but until you fix the faucet itself,
you're going to have a wet floor.
You're going to have a problem, right?
Yeah. That's a great analogy. So how do you even begin to tackle something as complex as addiction?
Right.
I mean, where do you even start?
Well, it's definitely not a one-size-fits-all situation,
right,
just like with the infection. But there are tools, there are medications that can be really helpful for people.
Medications for addiction?
Yeah. You've probably heard of methadone.
Sure.
It's been around for decades. Used to treat opioid addiction. It basically acts on the same receptors in the brain as opioids, like heroin, but it's more controlled.
So it kind of takes the edge off the cravings?
Yeah.
But without the dangerous highs and lows.
Exactly. And then there's another one, buprenorphine, which works in a similar way. It actually has something called a ceiling effect, which means taking more than a certain dose doesn't give you a stronger effect.
Interesting. So it's kind of like a built-in safety mechanism.
It is. But here's a really key point. Both methadone and buprenorphine, they're most effective when they're part of a bigger plan,
Okay, so it's not just about taking a pill and calling it a day.
Definitely not. We're talking a holistic approach here.
Right.
Counseling, therapy, support groups, addressing the whole person. The physical, the psychological, the social aspects.
It takes a village.
Okay.
So I'm starting to see this bigger picture. It's not just about fixing Emily's heart valves. It's about helping her reclaim her life, basically. But I gotta ask, doesn't all this raise some ethical questions, too? I mean, it's a really complicated situation.
It does, absolutely. And Emily's case brings up some of those really tough dilemmas that, we as healthcare providers, we face all the time.
So, give me an example. What kind of ethical challenges come into play here?
Well, one that comes up often is the question of OPAT, outpatient intravenous antibiotic treatment.
OPAT. So basically sending someone home with an IV to keep getting antibiotics.
Yeah, that's the gist. It can be a great option for patients who need a long course, but they don't need to be in the hospital,
That makes sense. Get people back home, free up hospital beds. So what's the ethical dilemma with Emily?
Well, remember, Emily has active IV drug use.
Right.
So giving her a central line for OPAT, that brings a real risk of reinfection.
Because she could use that same line to inject drugs.
Exactly. It's a tough one.
At the catch-22. Yeah, that's a really tough one.
Right. On the one hand, OPAT, she could go home, regain some independence, maybe even start really focusing on her recovery. But on the other hand, it could put her at risk for more complications.
Yeah. You're trying to balance her, I guess, her immediate medical needs with her long-term well-being and her autonomy, right? Her right to make her own choices.
Yeah.
It's tough. How do doctors even start to, I guess, figure out these situations?
There's no easy answer, and there's no, one right answer for everyone. It's really about looking at the individual.
Okay. So, pop quiz time again?
I was hoping you'd say that. Hit me.
All right. What's a common concern regarding OPAT for patients with active IV drug use? Is it A, difficulty accessing healthcare facilities?
Yeah.
B, increased risk of complications from IV medications just in general? C, risk of reinfection due to continued drug use?
Right.
Or D, lack of social support?
Oh, you're good. You're good. I'm going to say C.
You got it.
Risk of reinfection.
That's a big one.
Okay. Yeah. It really highlights, medical decisions. They're not always just about the science. It's about people, choices, real life.
It's messy.
It is.
It's complicated.
It is.
And Emily's case it's a powerful reminder of that.
Yeah.
Okay, so we've talked about OPAT, but there's, I think, another big elephant in the room that we haven't really touched on yet.
You're right. What about surgery?
Yeah, the surgical option. Why is that so ethically complex in this situation?
Well, so, surgical management of infective endocarditis, it often involves replacing the infected valve with a prosthetic one.
Okay.
So in theory, it sounds good, right? You swap out the bad part. But here's the thing. Prosthetic valves, they can become a new target for infection.
Ah, I see. Especially if someone's still actively using IV drugs.
Exactly. So then it becomes this big question of how many times do you replace a valve?
Wow. That's a tough one. How many times is too many times? Is there even an answer to that?
Well, some healthcare systems, they actually have this thing called a 3 strikes policy.
Like in baseball.
Kind of.
Yeah.
It basically means that after 2 valve replacements for reinfection, they might not offer a third one.
Wow. That's a really tough stance to take. I imagine that's pretty controversial.
Oh, it is. It is. There are very strong arguments on both sides. Some people feel that resources should be directed towards patients who are, more likely to benefit.
I see.
Others argue that denying someone a life-saving procedure because of past behavior, that's discriminatory.
Right. So it's like this moral maze.
Right.
Every path you take leads to more questions.
Yeah. That's kind of the nature of ethics, right?
Mm.
Makes you think.
Yeah, this case is fascinating. We're talking about a medical mystery wrapped up in all these ethical and societal questions. That's a lot.
It is. And it really challenges us to think beyond just the textbook. Think about real life, real decisions.
Absolutely. Well, he's definitely given me a lot to think about. Emily's story has really shown me just how complex medicine can be and the tough choices that healthcare providers face all the time.
Yeah, it's not easy. It's not easy. But, it's a good reminder that medicine, it's not just about the science. It's about people.
It's about choices.
Choices, values, all of that.
The messiness of being human.
Exactly. And Emily's story is it's a perfect example of that. It's about so much more than just treating her infection. It's about seeing her as a person with struggles, with hopes.
And potential for healing.
And potential for healing, exactly. I think we've given our listeners a lot to digest here.
We have. We've covered a lot of ground.
Yeah, this deep dive, it's about immersing ourselves in something complex.
Coming out the other side, hopefully, with more understanding.
More understanding. All right, so Until next time,
Keep exploring, keep questioning
keep diving deep.
into the fascinating world around us. As we've been going through Emily's case, I keep thinking about how it's really just like a small example of something much bigger.
Yeah, yeah. You get focused on the one patient, but Emily's story, it makes you think about healthcare as a whole.
Yeah, like how do we balance what one person needs with what society needs? Where do we draw the line when, there's only so much to go around, right?
Absolutely. Emily's case really shows that tension between, individual autonomy, like making your own choices about your body and also being responsible with healthcare resources.
Right. You can't have it both ways. At some point, tough decisions have to be made. Who gets what?
And it's even more complicated when you bring in substance use disorder.
Because people tend to judge,
Yeah.
right? Like, oh, they brought this on themselves.
It's true. There's a stigma around addiction that makes it hard to see the person, not just the disease.
Like we forget, it's a medical condition.
What? Yeah.
Biology, psychology, social factors. It's not just willpower.
Right. And ethically, we have to care for everyone, no matter what their situation is or the choices they've made.
But even with the best intentions, there are limits, right? We can't do everything for everyone.
That's the reality, unfortunately. Resources are limited, so we have to have these tough conversations.
About how to prioritize.
Exactly.
So how do we even begin to figure that out? Balancing individual needs, community needs, it's a minefield.
That's the million-dollar question, right? I don't think there's one answer. It's going to take a whole societal conversation. Policymakers, ethicists, doctors, the public, everyone.
This goes way beyond just the hospital, doesn't it? This is a bigger conversation we need to be having.
Absolutely. What kind of healthcare system do we want? What are our values? What guides our choices? Those are the questions.
Wow, this has been eye-opening. It's not just about Emily's health. It's about these bigger ethical questions, the challenges we face as a society.
Yeah, and it reminds us that medicine isn't just about the science, right? It's about people, choices, values, the whole human experience.
We went from one patient story to some of the biggest issues in healthcare. That's quite a deep dive.
It is, and as we wrap up, I'd love to leave our listeners with a question to think about. What are your thoughts on balancing individual autonomy and responsible use of healthcare resources, especially in cases like Emily's?
Tough question. No easy answers, but definitely worth thinking about. Makes you think critically, start a conversation, hopefully strive for a better world.
Well, thank you for joining us on this journey. Hopefully it's made you curious and you understand a little bit more about medicine, ethics, what it means to be human.
Until next time, keep exploring, keep questioning, keep diving deep into this fascinating world.